So we are live in three, two, one. Good evening, everybody, and welcome to this another episode of Wednesday Musing on a very important topic that I'm sure everybody of us who is in clinical practice has faced some time or the other. Unexpected orthopedics is a branch where mortality is uncommon. So mortality is like a big event for us, and I'm sure it is for most of the doctors, but for us it is many times we have difficulty in dealing with these situations. And I'm sure with experience of Borate sir, we are going to share a lot of insights into this difficult problems that we have to face. For further proceedings, I'll invite our convener, Dr. Tarang Karnar. Over to you, Tarang.
Yeah, hello everybody, and what Ashok Sham sir said, it really echoed my feelings as well. And the reason why we are doing this we are going ahead with the Wednesday music with these unique topics, is that not just the future orthopedic surgeon should be able to do complex surgeries, but he should be also able to handle such delicate issues. And very rightly, we discussed about handling complications in our last talk. And of course, death is the most dreaded complication. So here we are today discussing about handling of an unexpected death of an orthopedic patient. And what better guest speaker to have with his experience? Borate sir is here to enlighten us, and definitely it is going to be a very insightful talk. So, sir, why is there a need for our young surgeons or orthopedic residents to know, first of all, how to handle the death? To start with that, sir.
See, first of all, what I have seen is that most orthopedic surgeons during their training, there is no special training given to them about how to handle the death of a patient in an effective and compassionate manner. Now, even though it is not specifically and properly taught, during the 3-year course of a resident, they do come across one or two or few cases of patients who die while they are under treatment. But these are patients whose morbidity and high risk and poor condition is already known to the relatives. So usually the death of such patients, not a big problem in terms of stress and in terms of uh, you know stress to the orthopedic surgeon and the entire hospital. The problem of death in an unexpected manner, that means a patient who is undergoing surgery, and even if he is a high risk patient, even if we have told the patients that the risk of his dying on table is there, even then, when the actual event occurs, it does pose a problem. And even more importantly, a patient where we do not really expect anything in terms of a catastrophic event, uh, how to deal with it when such a patient dies. This is something that I think we should take the trouble to teach all our residents. Um, I'll just, I want to also start with some statistics that if you look at the prevalence, it is about 1.3 per 100,000 surgeries. Okay. So for every 100,000 surgeries, we do get 1.3 patients mm, who get sudden death. So one could say it is 0.1 to 0.13%, let's say, or even less. But the thing is that it still does occur. And amongst these unexpected deaths, it has been estimated that zero point 0.5 to zero point 0.8 per 100,000 are patients due to errors in the anesthesia. Okay. Now let's look at who are the patients amongst this small subset of certain deaths who are going to be the most likely. One group is people who are elderly, because people who are elderly usually already have morbidities, already have coexisting diseases. And even if they apparently do not have any disease, the stress of the surgery itself and the problems relating to the anesthesia or the surgery may lead to an unexpected event like a cardiac arrest or something, and may endanger the life while the operation is going on. So this elderly is a relatively high risk group, and so is the other group of neonates and young infants, because of again the same thing, that usually they may have problems that are not uh, properly understood or titrated while administering them anesthesia, and sometimes they may have some unexpected deterioration during the operation. Now, the anesthetists have a mechanism called the ASA grading to determine how much of a possibility or risk is there in a patient undergoing surgery. So they normally screen all patients, and they use this ASA grading to tell us what is the likely possibility of a problem. Now, for example, for ASA grade 3, they say that the mortality rate is about 1.8%. But for a patient with ASA grade 5, the on-table mortality goes up to 9.4%. So with the ASA grading, they can isolate or let us know which of the patients are extremely prone to getting severe catastrophic problems and dying on the table. With such patients, all the proper precautions like talking to the relatives, taking appropriate consents and all that is done fairly well. But we are now coming to patients who apparently do not have any problems. What could happen or what could go wrong during the anesthesia? So, one thing that has been found is hypersensitivity to anesthetic drugs. I mean, the patient may not have a allergic diathesis, or may not we may not be aware of it, but he may respond in an abnormal manner to the anesthetic drug, which after all is a chemical. There are also other things like muscle relaxants. For example, during my career, I have seen a patient who was given scoline as a part of the relaxation, and the patient did not recover from the scoline. And this was a very rare syndrome. And the anesthesia department had to keep the patient in intensive care for about 3 to 5 days. And fortunately for everyone, the patient did recover from the effects of the drug and recovered completely normally. But this unexpected response to scoline can lead to, because if, see, this happened when I was in a large tertiary care hospital, had a intensive care, and which had anesthetists who were senior enough to take care of the patient and keep him in good condition under artificial respiration for the required 3 to 5 days till he recovered. But this may not happen. I mean, if something like this had happened in a small nursing home or in a primary care or a secondary care center, it is possible that this could lead to a death on the table. There are other errors like overdosage. I have seen myself a patient who, in those days, ether was being used and there was very poor monitoring. And a patient with ether went into uh, what we call as fourth stage anesthesia. And then, even though the anesthetic was discontinued, it became difficult and the patient had like a coma and so on. So, overdosage, wrong labeling of drugs, inadvertent administration of drugs through wrong routes, lack of experience, and some accident during intubation has been seen. I remember operating on a patient where the anesthetist was unable to put the tube, and we postponed the surgery and got a tracheostomy done, and then took up the patient after a few days for surgery. So these things can happen, and sometimes if the infrastructure and the anesthesiologist not experienced, they could give rise to catastrophe. Of course, there are other issues which really are not human failure, but they could be because of defective pipelines, malfunctioning of apparatus that we use, kinking of pipes, and so on. I mean, there could be other things that also may inadvertently lead to some catastrophe. So these are some of the things that anesthetists uh, should be trained and should be normally aware and should have in their mind how they will avoid these things, and in case they occur, how they will deal with these things. Um, there are some surgical issues that we need to know, like, for example, when we are operating on blood vessels like the aorta, thoracic vessels, or surgeries in areas where the major vessels are quite close to the operative area and potential of getting damaged. And of course, normally speaking, any emergency surgery in an orthopedic patient or cardiac and neurosurgeries are much more riskier in terms of uh, something happening on the table itself. And we must also finally accept and learn to share with our patients that 100% successful performance of surgery is not practical. There always lies a risk of death in every surgery, as there are always standard or high risks involved. Sometimes we operate on patients who are in very bad physical shape. Sometimes unexpectedly something happens, like bleeding or accidental perforation of organs, and so on. So these are things that we have to understand and be prepared for, and also accept as a part of the process of surgery. Whenever something like this happens and we know that the patient is doing very badly and the patient is we're likely to lose the patient, we still have to be calm and attempt resuscitation to the extent that we can, and try to save the life of the patient. And in that process, whatever intervention, intubation, ventilator, transfer to intensive care, whatever is needed needs to be done on a priority basis before doing anything else. So, trying to save the life and not giving up on trying to save the life till we are absolutely sure that resuscitation is not going to be of any use is the first thing that always should be uh, attempted. And the entire team that is available should be called in. That is, not only the surgeon who is operating and the anesthetist, but all other available experts and seniors who are available should be called. And then everybody should work together as a team to do their best for the patient. This is what creates a very positive impact on the patients and the relatives in general. Once we know that we have lost the patient, then there are certain things that need to be done, like checking of the equipment and the drugs and so on. And also, one thing that while the resuscitation attempts are going on, it is good to delegate or designate one person who will be recording whatever is happening and the sequence of what was given and so on and so on in a shorthand or a quick manner, so that he can then reproduce it into the records. Uh, while the emergency is happening, it may have to be done manually. And it is important that every detail uh, and everything that has been attempted or followed, including uh, perioperative checkup, when it was done and by whom, and all those things must be ensured that they are proper and they have been properly uh, filled up and documented. One thing I have noticed in the last few years, I know this might sound a little alarming to you or to some of the listeners, but when such a catastrophic event happens in a smaller setup where there are not many barriers between the patient and the records and the personnel, I have seen that relatives of the patient sometimes just run away with the records, and they get them photocopied, and after some time they bring them back. And the explanation given is that one of the relatives became very agitated, but now he's come down and we have everything is fine. So the attempt is that whatever was incomplete in the records remains as a part with the relatives, so that they can subsequently use that as a mechanism to say that the records that were subsequently produced in the to the courts or the authorities were doctored and then produced to the authorities. So this is something that I have seen happening. So one has to be careful and one has to be aware of these things, especially the staff and everybody, that the records are important and they should not be allowed to be taken away and in the manner that I just said. And if such a thing happens, it must be also recorded and uh, mentioned in the FIR and whatever happens at the level of the police and regulatory authority. After an event, the anesthetist is usually under a lot of stress, and the surgical team is also extremely agitated, and they feel very bad that something happened which they had no control over, and somebody did something wrong or somebody didn't do their job well, and that's why whatever happened. It's very necessary that the anesthetist must be supported because he or she is already under a lot of stress and trauma. So one must try to get some senior people as soon as possible who will take over and reassure and make sure that all the necessary things are happening properly. And the anesthetist is in a sense supported by other senior members who are available, not only from anesthesia, but also from the surgical side, who may not have been part of the operative process. Um, I think that this is very important, and generally, I have seen that this is followed, and it is necessary that a wrong signal of a conflict or uh, you know, unpleasant interaction between members of the team uh, can be noticed by the staff or heard, and sometimes it is not good for the overall future happenings in the case. Once this has been taken care of, the important thing that remains is to how to break the news to relatives and so on. So we must communicate properly and we must communicate with transparency. It doesn't necessarily mean that we have to tell everything that we know. We must show concern. We must be clear that to tell the patient that the incident was unfortunate. We must answer all their queries. Bad news should be delivered in a straightforward and honest way, avoiding medical jargon. The surgeons and anesthetists and other people also, like the nurse or somebody, if the interaction occurs with the team, then sometimes some other members of the team can also um, add and take part in the conversation in a way that makes the relatives and the people that are the uh, they don't get they it helps to calm them, because sometimes just one person uh, may be talking in a certain way, but two or three people talking together can complement or uh, help each other to provide information or say things in a way that covers up for the uh, limitations of just one person talking on it. Now, one problem that we have been facing in India is violence and vandalism after a sudden and unexpected death of a patient. This is commonly or more commonly happening because of two reasons. One is that there is an element of um, mm, a criminal element in our society who, generally speaking, form part of the larger circle of people who know whoever has been in the hospital. And usually, uh, such kind of people get involved because of the financial issues that are there in the process of the treatment. And there is already a certain amount of negativity in relation to the charges and so on and so forth of the hospital. So when such a unfortunate thing happens, the reaction of some of these people is to indulge in vandalism and threats and physical harm and injury to the hospital staff. Now, we have to be very clear that this is not acceptable and this has no protection in the law, and all such people are liable for criminal uh, action, and even if necessary, uh, punishment through the legal process. So again, we have to be aware that we need to uh, um find out the names of the miscreants and mention them in the FIR. We should nowadays most hospitals are having CCTV footage, which helps to identify what happened and who indulged in violence and so on. And it is necessary to take photographs and create records of what happened for the legal process as well. Um, it is necessary to send the injured staff and doctors for medical checkup, first aid, and investigations and records, because and create medical legal case with them as well, and preserve all injury reports. Saying all this because although it's an unfortunate and a very unpleasant uh, thing that may happen as a sequelae to the unexpected death, since it's happening so regularly, we need to be educated and we need to be firm and aware of what needs to be done and not be in a complete confusion. Especially, this is more easily possible in large hospitals and who have larger staff available at short notice who can come and assist the team that is involved in the incident. But in places where the hospital is smaller and there is not immediate availability of other medical people to come and help, and this becomes sometimes very distressing and unfortunate. We all know, or we should at least know, that whenever a death occurs during an operation or within the first 24 hours after a surgery, it is considered, for practical purposes, an unnatural death. Therefore, it has to be not only reported to the police, but also has to undergo the process of what we call uh, medico-legal procedure of autopsy to find out uh, what was the cause of death, and also to investigate if there was any um, lacuna or deficiency from the medical team and so on. So we need to know what is our duty, and therefore we also need to know that what is it that the police or the authorities will do, when they arrive on the scene. First of all, taking care of the dead body and taking it for autopsy, and after the autopsy, handing it over to the relatives or the family of the patient is now the responsibility of the police. Once the police arrive and take charge of the uh, body, it is no more the responsibility of the hospital. You should be aware of this. But at the same time, it is also one of the things that the police are expected to do is to take mm, possession or keep a record or take into their custody whatever equipment was used, whatever medicines were used, and try to determine what happened and take statements of all the members of the team that are involved. So, one of the things that we should know is that what the police or the authorities are likely to or need to document is that was the patient suitably prepared? Was the patient examined properly? Was the patient investigated properly? Was proper consent taken? If there were any issues relating to the risk relating to the operation, whether that has been documented, whether the anesthesia that was given was appropriate for the time for the type of operation, um, and so on, and whether the people who were giving anesthesia were skilled and had the necessary qualification, whether all emergency resuscitation facilities were available at hand in case something untoward happened. Um, because, these are all things which help the authorities to determine whether there was any negligence or deficiency or error on the part of the medical team. So we need to have all this. And finally, even if the complication occurred, what kind of resuscitation was done, what measures were taken, and so on. So all these things that we normally do, and everywhere I have seen that everybody does their best. And at most places, at least in the urban areas and in the kind of setups that we as orthopedic surgeons are working, there is absolutely adequate availability of resuscitation equipment, resuscitation facilities, and so on. But all this needs to be properly understood, explained, and documented. There is also sometimes, later on, a doubt might be raised about wrong administration of drugs or something like that. So it is necessary that all the empty vials of the drugs that were administered be kept as evidence so that it can be then subsequently explained to the inquest or the court or wherever this matter will be investigated, and there is no doubt or there is no problem. So all drugs, syringes, ampules, airway devices, etc., should be kept in a secured box. And after a list is provided and a copy is provided to the hospital, it can be handed over to the police if they need it. Normally, it all depends on investigating authorities how they decide to handle this. Another thing that again is now becoming more common is as soon as something untoward happens, the media come into the picture, especially in large cities and even in smaller towns now, with these 24-hour news channels and all kinds of, um, media reporting and videos and this and that. It is very likely that uh, very soon some information is received by somebody who will approach the hospital and try to record what is happening and try to ask the staff for statements and so on and so forth. So it's very important that as soon as something happens, it should be told to all the staff members that only one person who has been nominated by the hospital or by the team will talk to anybody uh, other than the relatives and family of the patient, who will be dealt with as a team. But other than that, everybody else will not give any information to anybody purporting to be a member of the media or of any channel and so on and so forth. Nowadays, this is the awareness amongst the medical staff is increasing. So we are having better compliance from the staff. But it is necessary to remember, and if there is a more than there is a forcible attempt to encourage the media and give interviews to the media by the relatives and so on, it is important that the police be informed to restore peace and order and get rid of any people who have no business to be in that situation. Right.
So, yes, sir. Yeah. So, as you are going, as you are talking about all the drugs and checklists, and you covered about vandalism as well. That's very good points to ponder over. I was wondering if there is a mandatory guideline for the drugs check and the equipments and procedures if such situation occurs. Is there a mandatory guideline by the MCI or the ICMR, or it is subjective to the hospital's standard operative and SOPs? What do you have to follow in such case?
Yeah, good. Now, what you have raised is a good question. The MCI and the medical council, they have a set of guidelines which are necessary for all doctors to know relating to treatment. And we are going to have a special session on the guidelines for the doctors by the medical council. The all that guidelines actually are about 8 to 10 pages, and they cover all aspects of medical treatment, including operations and including deaths and including medical, legal, and everything. So those guidelines are generally very broad, but two things have happened which have improved the guidelines and checklists that are being followed. One is the accreditation required of hospitals and of teaching institutions by the NABH. So the NABH or the accreditation authority have given better and more detailed guidelines about how anesthesia department should be managed and what kind of preoperative checklist is required for every patient and should be followed by the anesthesia department, by the surgical department, including the formats for consent, informed consent. Informed consent at one time used to be not so detailed, but now the in the last few years, a lot of additional clarity has come in what should be and what should uh, all be included in informed consent. The other thing is also that certain safety precautions like checking of equipment before the surgery, record that yes, everything has been checked, then a surgical timeout before beginning the operation, ensuring that the part to be operated has been labeled and it's confirmed before the surgery begins. So there's so many things that we are doing to ensure that whatever that we can prevent or avoid through being vigilant and checking and rechecking is done properly and to the fullest extent. So that is there. One thing that I want to talk about now is what we should do as a routine in all our patients who are undergoing operation before they go on the table, because these are the issues that will show up and create problems in the unexpected catastrophe. If we deal with all our routine and apparently healthy patients with the same amount of diligence that we give for the seriously ill or complicated cases, then we will be in a better shape and a better situation. So, this whole concept of taking uh, adequate care and diligence with all patients is what is called as the proactive phase of medical care. That is the period before whatever happened has happened. So, the first thing that we need to be clear is that we have to appear and demonstrate credibility and establish fiduciary responsibility, which is another way of saying establish trust. We must, the patient must uh, be, we should create a bond uh, in which the patient decides to trust us. And to earn that trust becomes difficult when a casualty, a patient has come with trauma and his life is in danger, and he is seeing the orthopedic surgeons for the first time. The family is meeting with the doctors for the first time. So these are situations where we are at a disadvantage. But as soon as possible, or as much as possible, we must create this trust. And to do that, it is necessary that we must change our approach. The approach in the past used to be that 90% of the doctors would believe that don't tell the patient too much because the patient will then get scared. And it is not necessary for the patient to know things that will frighten him or her, and so on. But today, those things are not valid anymore. And we must also know that when a patient comes to us for treatment or discuss treatment, he already has taken trouble to acquire knowledge. He has researched for probably information. And so we should be completely open and we should share our knowledge and with the patient, thereby creating that trust. And another thing is that we often, when we discuss a plan or suggest a plan of action for a patient, which includes an operation, we tend to follow a pattern of giving the information in a medical fashion with medical terminologies. And because we know that information very well, we tend to do it in a rapid and a quick manner, which sometimes and most of the times leaves the patients a little dissatisfied. So that is why we must be very careful that when we are talking to a patient about an operation and we wish that the patient takes a decision based on what we are telling him, then we must talk to him slowly and in great detail. We must use visual aids. We may use some videos. We may use some slides to show them the steps of what is going to happen. And all the while, we must maintain eye contact with the patient, and we must be willing to listen to any questions or any doubts or any uh, thing that the patient wants to know from us. Another technique that is advised is after you have finished telling what you have, uh, if the patient is asked to repeat in their own words what they have understood, that helps to revise, and that again is included under the heading of reflective listening. I like that word, reflective listening. So we not only listen, but we reflect on what we have heard and then try to give additional information or confirm whatever we have listened. Another thing that we often forget is what is termed as anticipatory guidance. So, anticipatory guidance means that we explain what are the common complications that could happen during the operation and after the operation in the process of recovery of the condition which the patient has. So, in case of fracture, it could be delayed union, malunion, non union infections. But there is a set of things that could happen as a part of or during the course of the operation, which also needs to be told to the patient as a part of giving him the necessary information in order to make an informed decision. Okay. So the other thing is that while we are doing all this, if we show that we are not in a hurry, if we show that we are an active listener, if we listen and sometimes repeat more than once to other family members because they may not have understood or they have some questions which may appear to be a little simple and irritating. Even then, if we demonstrate patience and compassion, then what we are getting is we are giving the patient a feeling that we care for him without actually saying it. So please remember that in every patient, the unhurried time that you spend communicating with the patient is a demonstration of unspoken caring, and it will go a long way in making the patient feel uh, you know well towards us should an adverse event occur. Because when an adverse event occurs, the patients are often likely to go back in flashback and start thinking about what happened and how the doctors behaved and so on. So all these things that I just said will go a long way in uh, creating a positive uh, impression about the doctor, even when something unfortunate has happened. And we must also remember that patients are not just bodies, they come with minds. And also, as doctors, we have the benefit of education, we have the benefit of coming from a socioeconomic strata of society. which makes us different from many of the patients whom we treat. So our patients may come from different religions, they may come from different strata of society, different social backgrounds, and even spiritual backgrounds. Now, this is something that I found very interesting. I must share that um, in a study, they found that 59% of patients said that religion was very important in their daily lives. 60% reported that they pray at least once every day. 64% prayed for their own health. 68% prayed for the health of others. And 80% believed that personal prayer or other spiritual practices could help in the medical treatment of any people who are ill. Now, in addition, 63% believe, now this is very, very important to know. 63% believe that physicians or doctors or surgeons, if requested, should join the patients in prayer to ask for help in curing an illness. And 34% believe that prayer should be a standard part of the practice of medicine. So just like in airports, we have praying areas and areas of spiritual um, things for passengers. We must understand that these kind of opportunities and um, facilities should be there in hospitals as well. I used to not understand all this throughout my career, but now I realize how important it is. And this is the thing that patients also report, that only 10% of doctors actually discuss all this with their patient. Although most patients, as we have seen from the previous data, are religious and are spiritual, but doctors somehow tend to ignore and not bother about these things as much as they should. So 10% of doctors being interested or sensitive or caring about all these things doesn't reflect well on the on our profession. And uh, I can also vouch that I am also part of the 90% rather than so that's the reality which we need to reassess and change. So we need to ask our patients, um, are they religious? If they are, then we must uh, say that okay, we understand, we respect that, and we should ask them whether we can help them in any way uh, with whatever they need in order to do whatever they want to in terms of prayer. You know, if they say we have gone to this temple, we have brought this prasad, please take it. We should take it. We shouldn't like say that, or we shouldn't buy non-verbal actions give the impression that we don't think much of all this. Um, so this is what I thought was very important, because these are some of the things that even I had never reflected on in all these years. Now, obviously, when something goes wrong and the patient dies, we do these things. We need to scrutinize the preoperative care and all that. We need to be honest and humble and acknowledge errors if those errors are uh, obvious and will have to be part of the subsequent things that happen. We must learn and carefully think about before we uh, put into words the circumstances of what happened. And as I already said, when we are talking to the patient's relatives and near and dear ones, it's better if we have a team that is more than one person. And we have a proper setting, because like if as doctor we have come out of the operation theater with blood on our clothes and all that, we should not engage in talking to patients without uh, getting ourselves reorganized. And also, we should find a place which is quiet and which is for proper seating, and which patients, if they want to cry or if they break down, all these things are available. And it's not in a public or a place where it becomes difficult for us to control what is happening or allow what is happening to happen in a manner that is conducive to people expressing their grief. We should, as we've already said, tell them what happened and so on. And also, after they have understood all that, tell them what now needs to be done and seek their support for all that. So that it is not like we shouldn't say that uh, we have already called. We should say, okay, now this is what is going to happen. We are going to inform the police. We're going to call them. This is going to happen. Autopsy is going to happen. Whatever. And so that they become uh, kind of they understand the sequence and learn to accept it and so on. Um, and see, grief, when somebody is sad, somebody has to deal with death and something, then people need to sometimes cry. Sometimes sometimes they may be in shock, they may be in denial, they may disbelieve.
Yeah, the 7 stages of grief
Yeah,
to undergo. Yeah.
yeah, and then they may, in some cases, move to the next stage of grief and become emotional and start crying. And then they may go to the next stages and at some point come to acceptance and peace. The length of time required for this may vary greatly, and it is important that uh, if amongst the family and nearer dear ones there are older people and people who have seen life uh, and face such kind of situations, so they will be a big help in bringing a kind of calm and um acceptance better than if the near and dear ones only consist of young people or people who are uh, excitable and so on. Um, before we finish, we need to also remind ourselves that the doctors also need to be cared for, because they may become victims of the shock and the stress of what has happened. And as we all know, self care is not usually a part of our education and is generally low on our priorities. Surgeons don't seem to care as much about their health and well being as they should. And we often lead unbalanced lives in terms of work, commitment, family relationships, personal recreation, rest, and reflection. We want to be perfect all the time, and this leads us to deny our own personal needs more often than not, even our feelings, even our uh, need to relax. And that is what we become sometimes altruistic to the point of denial. So these are all things that prevent us from, psychologically giving ourselves a break. And that's why I would like to just say that uh, for all the young surgeons and people who are active in practice, uh, they need to learn to value themselves and care for themselves and love themselves and value their own needs. They need to learn to say that they don't know something. It is not possible for them to all the time keep saying that they know everything about everything. So if they don't know something, they must accept it as well as articulate it. And they must also learn to say no to some things that may not allow them to lead lives like other normal people. And of course, these are things which we all try to do. We all try to remain optimistic. We try to enjoy our friendships. We care for individuals that are important to us. We we should take care of ourselves. We should have a sense of humor and keep doing things that we like and believe that we can change and reduce our shortcomings and work and expand our good qualities.
Yes.
I just want to end with two things, which again are of interest to Dr. Sham and to researchers. One is that one study, one large study which tried to investigate unexpected deaths within 72 hours in emergency rooms in hospitals, they found that more than half of those patients had a medical error that could have been prevented. And usually, that medical error consistently happened to be under detection of sepsis. And that means patient was apparently not manifesting signs of severe sepsis. Apparently, his vital parameters seem to be okay. He didn't seem to have major signals of sepsis. And in the course of trying to find out what is wrong with him, the treatment and the aggressive treatment that was needed for sepsis didn't happen. So I urge everybody to remember that when you have a patient who has come to your emergency room and you have to you don't know what is wrong with him, you are investigating him. Even then, it is important to always remember this thing about severe sepsis and the possibility that the patient may go into a irreversible septic shock. And so the common things that normally we do till we get all definitive investigations should be done. Because I thought that this finding is very important. The other thing also that is there is in surgery, there is something called as a POSSUM audit tool. This POSSUM audit tool looks at physiological factors and operation related factors, which are used as variables to uh, have a scoring or as a tool to find out the risk and the mortality and morbidity associated with a given patient with a given problem. Now, data suggests that these tools have been tried out in orthopedic patients as well, and they have found that the risks that were predicted by the audit, which was done during the course or as a part of the treatment, um, co- you know, correlated with the percentage of the severe complications that uh, happened in the form of mortality in patients uh, who were of high risk. So we must always uh, be mindful and learn from whatever happens or whatever happens in an unexpected manner. So I just wanted to tell the listeners that there are tools and this is being done, and most large hospitals should have some kind of program like this, which they should share in a form that will improve the collective knowledge and wisdom of the entire medical community to bring down the incidence and severity of these problems. Right.
Right, sir. Absolutely, sir. So, a really nice, insightful talk. The first half, sir, covered the medical aspects, the technical aspects of how what can happen in an unexpected death, why it happens, and yeah, the checklist, the equipments, and the procedures and the works to be followed. And in the second half, sir introduced us to rather, I would like to say, some intangible concepts like reflective learning, anticipatory guidance, and unspoken caring. And I found very interesting and surprising was the stats which sir presented about religious and spirituality. And if in that case, if going by those stats, I feel it is very important for myself as well to start showing my religious and spiritual aspect in my daily practice if I'm operating on someone. So excellent talk as usual, sir. Not just the technical and medical part, but then how to handle, and yeah, very importantly, the self-care part. I think one should say no to overburden. A surgeon needs to learn that. A surgeon needs to take a break and give time for himself, vacation, whatever hobbies, and say no to overburden of work. And exactly, possum audit is also a very important part which sir mentioned. So, Ashok Sham sir, and to another insightful, and it's especially insightful. I'm stressing on the word insightful is because this is coming from vast experience, and I wouldn't experience or I wouldn't get any knowledge unless I've spent 25 years in the orthopedic practice. So it's very important for me such topics personally as well. Over to you, sir.
Yeah, absolutely. So we covered a lot of areas through the entire process. And like sir said, issue with medical science is it's not an exact science even now. There are so many variables, and doctors working in stressful environment where patient is having difficulty or patient is critical, we as human beings cannot account for or unable to account for all the variables. Some variable, like he said, sepsis can be underdiagnosed. There's so many variables that define sepsis in a given patient, and generally we catch the common ones but may miss out the uncommon ones. So the point is, it's an evolving thing, the medical science, and as it evolves more, we'll be able to save more lives. Again, dealing with the death of a patient, how it impacts the patient's relatives is very, very well known. But how it impacts the doctor is still not, I mean, it is a very, very personal part. Many of our colleagues and even me personally get very, very impacted by death of a patient. I mean, it is a very difficult situation emotionally, professionally. The main part is we have nobody to share that with. Now, patient's relatives have so many, I mean, have their support system. But we as doctors or professionals, we don't have any support system to support us in that emotional crisis or whatever we call it, professional crisis, both. So generally, even in doctor community, uh, even talking to each other, it is very difficult to acknowledge something like that, isn't it, sir? It's very, very difficult to acknowledge even to our colleagues that I am affected emotionally or professionally by a death in our hands. In fact, we put up a brave face and say that, okay, we are not affected at all.
Yes.
Most right. So, I mean, that is something that I know personally and felt personally. So I'm sharing that experience. Something can be done in that area too, to be more open about how we deal with it.
Yes.
Yeah.
See, two things that I forgot to mention. One was that in a hospital where there are multiple theaters and operations going on, if something untoward happens during the course of one operation, There should have been a standard policy that all the other theaters also should not operate or take time off to help this particular incident to be handled in the best possible manner, and maybe if required cancel the remaining list so everybody is available to deal with this, and the other operations are not the victims of the stress that has resulted in the team of doctors as well as anesthetists. The other thing also that has been recommended is to take some time off uh, mm, after such an incident or something that has happened, that the outpatients and further operations and so on be kind of delayed or postponed by for some time, uh, so that the doctor gets enough time to 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 get back into a to come to terms with what has happened, and
Absolutely.
is in a position to confidently and in a reasonable manner go back to his work. So this again is what you said is right. Sometimes in our hospitals and in the way we function, we don't do that. I mean, I remember I underwent a major polytrauma and fractured all three limbs out of four. And after being operated, and after about 10 days, my patients started coming to see me where I was. And they started asking my advice about whatever was happening, because I was in my own hospital and everybody knew. So patients who came said, at least let us go to see the doctor. But once they saw me, they forgot about what was wrong with me. They were more interested in telling me about their own thing. So I naturally ended up with a prescription pad and, uh, started being. So after a couple of days, I decided that on the crutches, I will go and sit in my consulting and deal with all these things rather than, so yeah, this is unfortunate, but that's the way we sometimes have to deal with our practices.
Okay, Tarang, I think we are at the end of the session today, and you can summarize, and Borate sir can have some last comments. You have to unmute yourself.
Yeah, so I already summarized in the first half. We discussed about the technical aspect, the medical aspects, and then very wonderful unknown terms sir introduced us, like unspoken caring, anticipatory guidance, and reflective learning, and which I'm going to Google now for sure. And also the surprising statistics on the religious and spiritual aspects, and that was very interesting. And obviously there is awesome, and there is has to be a research to be done in that field. And very valid point made by you also, sir, that the what happens to the relatives is always spoken about, but what the surgeon undergoes when he loses a patient in such a way is also very important. And some work should be done on that, on those lines as well. Yeah, so I think that's a wonderful talk again, and we end up and see you on the next Wednesday.
Just one thing I'd like to say
Yes, sir.
is this whole musings that we are having have been a big revelation for me as well, because in all my practice, I can plead guilty of being focused and obsessed with diseases and fractures. And I saw all my patients as diseases and fractures rather than human beings. And when we look at and when we discuss these things, every time I realize how less we uh, engage our trainees and our doctors to think and become more focused on the human side of the patients that we treat. Because as we go into all these issues that relate to healthcare and its problems, we find that this is the area that we as professionals are neglected or have neglected, and have you know uh, been under the illusion that because we are doctors and we know so much about the human body, and we know so much about our own subjects, that all these things are of relatively unimportant. And with each of these musings, I realize how wrong we are. Because the more we realize, the more we understand. Like when you look at the literature, you realize that uh, the literature never told us, or we just didn't look at the information that was available and the advice and things that were available with the other disciplines of psychology, of sociology, of human behavior that impact our patients and our interactions with them so deeply and so intensely. And I uh, I understand that when we train ourselves and train our students, that there is so much to learn, and most of it is important because that's what they are specializing in. We give them the degree of master of surgery, so they need to know surgery more than anything else. But in this quest for making them good, competent, and successful surgeons, we uh, probably uh, fail in sensitizing them to many of these related areas, which they need to uh, learn more about. Not because it's going to be asked as a question in the exam, but it is an important part of making a successful surgeon. So a successful surgeon is not only a craftsman, is not only somebody who is mechanically creating, doing something and fixing a bone or whatever. He is also, he must understand and be trained in the human aspect of disease and patients and their entire life and their own world. Because as a doctor, quite often patients give us that respect. The patients treat us like God. They give us such a high position in their mental and spiritual space, and that sometimes we ourselves feel guilty when we realize how much we are being, you know, appreciated for so little that we have done for them in terms of our giving our own skills. That's it.
All right, sir. Thank you very much. So we call it off for today's meet.
Yes. Thanks a lot, sir. Thank you very much.